So good morning and welcome. As many of you who've attended these for years know, we've had this wonderful endowed lectureship that a patient of Dr. Sham's very generously gave us 25 years ago. It's enabled us to bring in big name speakers, mostly to speak about hematologic malignancy and related issues. And this year it is very special. Not only has it been 25 years since we started doing these, but we now have our own leukemia and bone marrow transplant doctor who's on the panel, Dr. Anne Renteria. So the program today is sort of two-part. Dr. Sham is going to give us a bit of history and walk us through the changes that have happened in the last 25 years. And then he will introduce Dr. Renteria, who will do the last portion of the presentation. So you now have 93 people in the audience, Ron. And the rules are as they usually are. Please use the Q&A section to ask questions online, and I will monitor that during the talk. And most likely we will hold all the questions until the end of both talks. But if there's something relative pertinent to Ron, we may pause and then take one. With that, I'll have Dr. Sham start the first part.
Good morning, everyone. Welcome to the 25th anniversary Burnham lecture. I'm going to start with a little bit of background about the patient. So Will Burnham presented in early July 1993 with hyperleukocytosis with a white blood count of 200,000. And a diagnosis of acute monoblastic leukemia was made. That night, it was of course in the middle of the night, he was treated with pheresis and then started on induction chemotherapy and then consolidation chemotherapy. In late 1993, he had an allogeneic bone marrow transplant from his histocompatible brother. And unfortunately, in January 1994, he relapsed and developed acute graft versus host disease and died from complications after spending almost, I think, 11 weeks in the hospital. It was quite tragic. His family established a hematology educational endowment fund in his honor, and we've had yearly visiting professors. And this has been quite an interesting thing to do, but I wanted to give a word or two more background about the family. On the left is a letter from his father. I used to send him a note every time we had this, and his father, who was quite elderly, would send me back a letter, and he would send me newspaper clippings from Pittsburgh, where he lived, every time there was something about leukemia. And I would send him a letter saying who we had speak. So here you can see it says, "I appreciate your letter," from, this is 2002. "Someday you will be talking about a cure for leukemia. Keep up the good work." So it's very, very moving. I think that was the last letter, and then he passed away. And on the right's a picture of Will's wife, Rosemary, who was babysitting for our dog right before the pandemic. And I show this to point out the importance of relationships with patients and their families. And I think this is particularly notable during COVID, when we don't get to spend time with our patients or their families sometimes at all. And I really feel particularly sad for our interns who have never spent time with a patient during their year as a doctor without a mask on and a shield and sat down with families. So hopefully the pandemic will be over soon, so all of us can get back to spending time with our patients and our families as we did in the past. So the lectures through the years have changed. Real quickly, we started with overhead projectors, Kodachromes, floppy disks, hard disks, CD-ROMs, then these flash drives, and now we're doing Zoom. And I am not in my pajamas, I can tell you that. So now also quickly, we had all these amazing visiting professors over the years. And I'm not going to go through every single one, but it really started with Dr. Lishman, who was my mentor. And these are some very well-known acute leukemia doctors. And then recently, Allison Walker, who was one of our trainees. So it's really nice to see both ends of the spectrum, someone who trained us and someone who we trained. A number of these folks are really world famous myeloma and Waldenstrom's experts. And John Bird and David Steensma are real leaders in CLL and myeloid stem cell diseases. They were young doctors when we had them here. And then David Porter was really one of the first people in the country to do CAR T, and he was on the national news one night about 10 years ago, or maybe 9 or 10 years ago. And I thought, well, that'd be really great to get him here. He's from University of Pennsylvania. So this is the kind of people we've had over the years. So it's been a very enjoyable experience. And we typically have them come in and have them do grand rounds and meet with our whole group. And this year is obviously different. So start with a little background about chemotherapy. In 1946, Babe Ruth is diagnosed with nasopharyngeal cancer, and he's one of the first individuals to receive combination chemotherapy and radiation. And the chemotherapy was a nitrogen mustard derivative. And for anyone interested in the history of the development of chemotherapy with some World War II history, this is a very interesting book about that called The Great Secret. So a couple words about chemotherapy versus targeted therapy. On the left, you can see chemotherapy typically is directed against DNA synthesis and mitosis. And these are many of the agents we've learned about over many decades. And in the last 10 to 20 years, we've had what I'm calling targeted therapy, and really two main groups: monoclonal antibodies, where there's a target on the surface of the cell, in this case, a leukemia cell, for example, and then signal inhibitors, where the target is often a receptor on the cell. And this is applicable to solid tumors as well as hematologic malignancies. Now, the toxicities of these can vary, and this is important for many of the primary care physicians who may see the patients in the office, because I tend to think of the toxicities of the traditional chemotherapy drugs as innocent bystanders. The reason you lose your hair with typical chemotherapy drugs has to do with the DNA synthesis and mitosis of the hair follicle. And that's not a typical thing you see with targeted therapy, but with targeted therapy, sometimes you see side effects because some of the other body parts have similar targets to the gene in target. I'm going to start quickly with CML. Most of you recall that the Philadelphia chromosome, which is this little tiny chromosome 22, was discovered in 1960, University of Pennsylvania, hence the name Philadelphia chromosome. About a dozen years later, at University of Chicago, Janet Rowley, who was an incredible hematologist, showed that it wasn't just that chromosome 22 was small, but there was an exchange of genetic information between 9 and 22. About another 15 years later, the actual genetic makeup of this was worked out further, and that's the combination of a BCR and ABL gene. And then it was subsequently found out that this codes for an abnormal tyrosine kinase here. And tyrosine kinases are enzymes that add phosphorus groups. And in the case of CML, the tyrosine kinase phosphorylates regulatory enzymes that have to do with hematopoiesis and leads to the disease. So this is a one gene disease. And it was discovered after many years of research that if you develop a tyrosine kinase inhibitor, and the first one here is imatinib or Gleevec, you can inhibit this gene product and alter the course of the disease dramatically. And all of this really developed after we started doing these lectures. So when we started doing these lectures in the early 90s, none of this was out there. So quick slide of the evolution. So before any of us were practicing was the original use of arsenic, then splenic radiation. And in the 60s and 70s and 80s, the mainstay were really busulfan, which is an alkylating drug, and hydroxyurea. In the late 80s, transplants started to be used. And then there was a period of time when interferon was quite useful. But really, it was right around the year 2000 that imatinib came into play. So really, about 10 years after we started doing these talks. And now there are newer agents as well. And this has dramatically changed the natural history of CML once these drugs were introduced. When many of us were in medical school, we learned about CML having a chronic phase, an accelerated phase, and a blast crisis. We don't typically see that much anymore. And so it's really a dramatic change. And I put the home run here for, this is really a home run drug, this whole class of drugs. So we're going to use Babe Ruth throughout the talk. Now, for acute myeloid leukemia, you also have genetic changes here, and this was known many years ago, and there are different karyotypes, and this has multiple gene abnormalities. So this is much more complicated in some regards to CML. And as many of you recall, there are different risk groups based on the chromosomal pattern, and I'm not going to go through each of these gene abnormalities, but there are lower risk groups, higher risk groups, and intermediate groups. And this was known back in the early 90s. But since then, this whole area of molecular abnormalities with acute leukemia was discovered. And this is an interesting type of diagram. Some of you have seen these. And these are gene abnormalities, molecular abnormalities that may not show up on the typical karyotyping. And many of the patients have multiple chromosomal and gene abnormalities. And these are now targets for some of the newer therapies, none of which existed when Will Burnham was treated. So he actually had one of the more worrisome chromosomal abnormalities back then that goes with monocytic leukemia, but we did not know about any of these findings then. Now back in and the key things here I circled in red. So the induction regimen that we still use goes back almost 50 years. So up on the left corner, cytarabine or Ara-C and daunorubicin. And this is being kind, saying 20 years with no advances. It's really more like 30 or 40 years. There were a lot of advances in the science of acute leukemia, but not in the therapy of acute leukemia. In around the year 2000, a monoclonal antibody, and that's the MAB here, MAB, was introduced. And this is targeting certain features of subtypes of AML. And it was actually taken off the market because of toxicity. And it really wasn't until the last 3 or 4 years that some of these new IBs, so the IBs are the small molecule inhibitors and the MABs are the monoclonal antibodies. And there have been 3 or 4 of these introduced just in the last few years. And what these do is they target some of the molecular abnormalities associated with AML. And this is not yet a home run, but hopefully in the future, this will prove to be much more useful, some of these targets. Now, one acute leukemia where there is a dramatic improvement over the last 25 to 30 years really is acute promyelocytic leukemia. And the use of all-trans retinoic acid was first published in 1988. We first started doing it here in Rochester around the time in the early 90s. And then arsenic trioxide was introduced in the mid-90s and was first done here in 1997. And currently there are what we consider chemo-free cures in more than 90% of people with this subtype of acute leukemia called acute promyelocytic leukemia, where you can see in the picture, the key hallmarks are impact on differentiation and programmed cell death. And this truly is a home run, one of the most major advances in the last 25 or 30 years in all of medicine. Now, multiple myeloma is a disease many of you are familiar with. We treat many patients here. Dr. Jamshed in our group has become quite a superstar in this area. And for many decades, all we really had were chemotherapy agents such as melphalan with prednisone. We started doing transplants in the late 80s and 90s. And around the year 2000, the drug thalidomide was introduced. And many of you know the terrible history of thalidomide, which was used in the late 50s and early 60s for hyperemesis, and it resulted in the birth defects seen in the picture here. And what it was actually doing, subsequently, we found out, was inhibiting angiogenesis, which in the fetus was affecting the limb development. And it was really through serendipity that was discovered to be useful in diseases such as multiple myeloma. And over the years, there have been advances with a number of related drugs we call IMiDs. This just started really 15 or 20 years ago. So when many of us started in hematology in the mid 80s, none of these drugs were even ever dreamed of. And this is a very complicated slide, but I don't want to go through all of it. But just to say on the left here that steroids and chemotherapy drugs, particularly alkylators, were used through the 50s to the 80s and 90s, and we still use these agents. Around 2000, the IMiDs, which are over here, thalidomide, lenalidomide, which is Revlimid, and pomalidomide, which are Pomalyst, are the 3 agents we use. One of the main side effects I think the primary care physicians need to know about is the thrombosis risk. So many of these patients end up on aspirin or anticoagulants because it's a fairly high risk. A number of years later, a group of drugs called proteasome inhibitors were developed, and that's these 3 here. You can see the names here. Bortezomib is also known as Velcade. So these drugs are known for their neuropathy. So if you have patients on these drugs with peripheral neuropathy, that may be a reason. And very recently, really only in the last 4 or 5 years, are monoclonal antibodies. And there's a third one that's been introduced. So now many patients with multiple myeloma get combinations of a steroid agent, a chemotherapy drug, and either an IMiD, a proteasome inhibitor, a monoclonal antibody, or sometimes multiple combinations. So this has all changed in the last 15 to 20 years, dramatically changed. Now, CLL, chronic lymphocytic leukemia, and I have here right around 1993 when Will Burnham was treated, fludarabine was introduced. And we hardly ever use that anymore, but it's still a very good drug. But before that, pretty much the only drugs we had were the alkylating drugs, chlorambucil, which is also known as leukeran, and cyclophosphamide, or Cytoxan. Any of the older physicians in the group and nurses in the group will remember that leukeran or chlorambucil was really the only medicine we had. It was actually a big deal when fludarabine was introduced in the early 90s. And then at the end of the 90s, Rituxan was introduced, and then combinations. But really, it's been in the last 5 or 6 years that some of these other agents were introduced. And the two key ones I'm going to point out here are ibrutinib, which has really been about 6 years ago, and venetoclax, which is really only about 4 years ago. And these have been commercially available for about 5 or 6 years, and really only the last 2 years for venetoclax. And these are small molecule inhibitors. Show you a little diagram here, which work very different than chemotherapy agents. And they are clearly home run agents from my point of view. I have a little picture of a patient clinical course. This is the white blood count. This goes back about 12 years. And this individual, when the white count got up to 150,000, was put on fludarabine and Rituxan, and it worked pretty well for about 3 years. He was only treated for about 4 to 6 months, and then he recurred, and then he got the same treatment, and you can see the interval's a little shorter. And then he got bendamustine, and then he was put on ibrutinib, and you can see now approaching 7 years, and he's just beginning to lose his response. So this is the future of some of these diseases using these small molecule inhibitors with really superb responses. Next, I want to turn to lymphoma and Hodgkin's disease, and not too much to say about this other than the development of monoclonal antibodies. And the main one is rituximab, Rituxan, also really a home run. This is a monoclonal antibody against CD20. Most of you know there are many monoclonal antibodies in use now, but in the late 1990s, this and Herceptin used for breast cancer were really the first two monoclonal antibodies. They're used in multiple areas of medicine. We use these in immunology, and nephrologists sometimes use this for lupus nephritis. Neurologists use this, and we also use this for other hematologic diseases, such as ITP and autoimmune hemolytic anemia. More recently, brentuximab has been introduced, and that's a anti-CD30 molecule. And again, the monoclonal antibodies have played a major role in the advances in hematologic malignancy. None of these were really even dreamed of when we took care of Will Burnham 28 years ago. When I was putting this talk together, I realized I forgot to mention this because in my slides, and I actually added this just a day ago, growth factors were also introduced right around the same time. And GCSF or Neupogen, and Neulasta is a long-acting version, and this has only really been around about 10 years maybe. But these agents enable patients to remain on full-dose chemotherapy. They enable them to remain on the desired treatment interval. So when I started, I was taught by Dr. Olson and others that to keep someone on a drug regimen like CHOP chemotherapy for lymphoma, you would often need to start the prednisone 3 days before the chemotherapy to keep the white count up. So now we use growth factors. Back then, we used to put people on prednisone early. And I think this has really increased the cure rate, and it certainly has decreased the morbidity and mortality from febrile neutropenia in many of our patients. Myeloproliferative diseases, we had a number of great speakers over the years. The science for this has advanced a lot with the discovery of JAK2 kinase mutations, calreticulin mutations, and the MPL gene, but the treatment has lagged some, and there are some JAK inhibitors on the market and some new ones coming. And this is a sculpture of the Janus god, I guess, from Italy. Myelodysplastic syndrome, another home run only in the 5q minus subtype where Revlimid has dramatically altered the success of that. But in the last 10 or 12 years, we have a number of other agents such as azacitidine or Vidaza, decitabine and dacogen, and very recently venetoclax. Some of you may have patients who have been on these agents. These are used for myelodysplasia, typically more advanced subtypes, and we also now use some of these agents in acute leukemia. Just a quick word about ALL, which I'm really not going to talk about other than to mention this one type of treatment, which again, very novel. It's called a bispecific antibody. These are going to become more common in the next 5 to 10 years. In this case, for ALL, there is a molecule that actually brings the tumor cell to a T cell. And this is quite a novel type of therapy. Again, something never dreamed of before. And I think Dr. Renteria will be helping us with this with other patients in the future. And then what I'm going to do now is turn this over to Dr. Renteria, who is going to talk to us some about CAR T therapy and bone marrow transplant. And these are endeavors we're going to be developing in the coming year. So it's going to be a very exciting time for our group. So I want to thank everyone for their attention. And hopefully it was interesting to hear about the last 25 to 30 years of hematologic malignancy. And now we're going to hear about the next upcoming 5 to hopefully 20 or 30 years with all the advances that are coming.
Thank you, Ron, for your talk, and here are my slides. I hope it's sharing.
Okay, yes. So now we're going to introduce Dr. Anne Renteria, who just joined our group in late 2020, and she's going to be leading the hematologic, the acute leukemia and stem cell transplant program with cellular therapy. She's been in practice more than 20 years, and her main focus has been acute leukemia, cellular therapy such as CAR T and bone marrow transplant. She has extensive experience, as noted on the slide, including work in the Mount Sinai transplant program and the leader of the ALL program at Mount Sinai. And so we have come to know Dr. Renteria just over the last 4 or 5 months, and she's an awesome addition to our team, incredibly smart and very approachable, and also, like in keeping with all of our colleagues in our group, excellent with patients. So I'd like to introduce her and have her spend the rest of the time going over the future of hematologic malignancy.
Thank you so much, Ron, for this nice introduction. Hi, good morning, everybody. So yes, I'm going to be talking what are, it's heading our field. So it's a complementation for heme malignancies, in the sense that some of them become really curable, and that's also what attracted me to this field a few years ago. And I'm going to just share with you some current trends in transplantation and adoptive cell therapies. So what I'm going to be talking about are transplant versus cellular immunotherapies, or also cellular and gene therapies. There are different names that we use all the time. And also because there are so many new therapies that are coming that some names, are still are lagging behind of the new technologies. Transplant, the current trends, autologous stem cell transplant, allo transplant, the CAR T cell therapies, what they are, which ones, and the obstacles, and what is the landscape. So first of all, I would like to just, show some notions of transplant versus cellular immunotherapy. The first one is immunotherapy, hematopoietic stem cell transplantation, or HCT. And this englobes all the procedures that we have stem cells of any source that are administered to a patient or recipient with the intention of repopulating or replacing the hematopoietic system. And this notion is important because when you do a transplant, what you are doing, except for the autologous, is giving you a new immune system. As I discuss always with my patient, for some reason, when you have a leukemia, your immune system stops recognizing the cancer cells. And when you do an allo transplant, what you're doing is giving a new immune system that will hopefully be able to recognize the cancer cells that gave the disease. So then in that notion, you have to think about the stem cell source. It can be from the patient to the same itself. So this is autologous. Or it can be given to another person, then it's allogeneic. And is it bone marrow, peripheral blood? So those are modalities of transplant. Then you have cell therapies. Cell therapies are the transfer of cells that carry relevant functions into a patient We do that for enzyme deficiency, for example. You have gene therapy, transfer of an exogenous genetic material into appropriate cells. So this is really targeted. You go into that cell, and then it's called transgene. So in oncology, we develop it to attack the tumor cells that otherwise, as I said before, would be ignored. Technological progress supporting the purification and manipulation of immune cell types have been growing and keeps on being refined. So the cell therapies, what we need to do and what we are doing now is learning how to select the ideal targets. What we want is to make sure that those cells only recognize the cells that we want to get rid of, which we're not there yet, but we are getting there. Because let's not forget that those CAR T cells, as we call them, they are living drugs. The moment that you deploy them in the circulation of the patient, they're gonna go after the target, but sometimes there are, targets that were not meant to be targets. And this is what we mitigate when we have adverse events. So this is what we have been seeing throughout the years. So the number of transplant has been growing. And this is true for autologous and also for allogeneic stem cell transplant. And as Dr. Sham also mentioned, one of the great advances that we had, it's not only the drugs that targets the malignancy, but the supportive care, which has been very, important in order to make sure that the patient is able to tolerate, survive, and thrive throughout this process. As you can see, the number of transplant continues to grow. And also very important, the age of the patient that are undergoing transplant is also increasing. Back in 2000, you would see that the proportion of patients that were above 70 was really minimum. But this was always thought to be, just a matter of time. Why? Because most of the heme malignancies, they are diagnosed when we are in our 60s and 65, when we are 65. So this is also very important. And also for our colleagues, the primary care physician, they are very often, the first ones to see that the CBC is abnormal and during a routine visit. So as you can see here, a lot of those patients, now that are in the above 70s, 60 to 69, or getting transplant. And allogeneic, it's not different. Same thing we are seeing. So we are having more and more patients above 70 that are able to undergo transplant. And one of the main reasons is because we have developed throughout the years reduced intensity conditioning. So it's much easier to tolerate. And this is to show you what we have. This is from 2020, last year. Those are the estimated new cases of leukemia, lymphoma, and myeloma. As you can see, this is quite seasonable. The amount of cases, almost 200,000. And we do allogeneic stem cell transplant for leukemia and for lymphoma. So worldwide, what I can share with you, which I think is extremely encouraging, the survival of patients that are undergoing allotransplant for acute myeloid leukemia continues to improve continuously. This was in blue. You have in the beginning of the 2000 to 2005, and then you can see in green 2006 to 2010, and then in orange the last 6 years between 2011 and 2017. And this is true, for across, the different analysis that we do. So the first one here is for survival. And then here for HLA matched sibling donors, you can see also, it also has improved, and unrelated as well, because we have improved also our capabilities in terms of finding and making sure that those patients are very well matched with the donor. So CAR T cells. So CAR T cells is a new technology that has been developed with T cells that are engineered in the lab. So what do we do? The one that we have currently available commercially, but I want to just share also that a lot of CAR Ts now are what we call off the shelf, and they are available through clinical trials to this point, but not for very long. And what we have now, we take some cells from the patient, they are collected at the hospital, they are sent to a lab. For now, they are big pharmaceutical companies like Novartis, and then they are reprogrammed. They are exposed to a viral vector, and with this viral vector, they are reprogrammed to now selectively recognize targets that are where? On the cancer cells. Then they are grown in lab, so we can achieve a good size of a population of those now new fighters T cells, and then they are shipped back to the facility and given to the patient, knowing that this patient receives before what we call lymphodepleting chemotherapy, to make sure that I create an immune system that is receptive of those cells. And then we infuse, and again, this is a living drug as well. And that's why you have the adverse events that sometimes you observe on those patients that we have to make sure that we manage, which are CRS and neurotoxicities. And then we wait, the counts recover, and those T cells, they do the job, and they just go after the cancer cells and kill them. Very, very effective, and some disease more than others. So now we have coming CAR NK or macrophage CARs that are actually collected from healthy donors that are not sick. And one of the reasons that this is also not only because it's easier to produce, but you can produce a lot of them beforehand and then just infuse when you have the right match. And you have other modalities of therapies that are called TCRs, meals, TILs, but they all fall under the umbrella of the CARs. So CAR T cell indications, and distribution of what we have been using along the years, you can see that when they are in clinical trials, very often it's for patients that are younger, but guess what? When they become available, most of the patients are again above 60 because that's where you have most of the cancers. So non-commercial, different distribution, but all the patients here, as you see, we are having more and more of those modalities available to our patients that are above 60 and 70s. So this is for the CAR T cells, the indication that we currently have. And you have here multiple myeloma, ALLs, non-Hodgkin lymphomas, and this is for the non-commercial. Those are the ones that we have available. And in the non-commercial ones, we have a lot of CARs also that are being developed for solid cancer. Not ready for prime time, but we are getting there. So what are the obstacles? So why are we not there yet? So the time to create and processing and making sure that everything is done according to quality settings that are in place, everything takes a very long time. This imposes delays. Sometimes the patient relapses in the meanwhile. So delays, very, very expensive. I have a slide for that. We are talking about $700,000 for each one. And we believe that with more cars coming to the market, this price will go down. And also because the technology become, easier. And we have now a facilitated route to produce them, so the price will come down. And also the need for uniform manufacturing. We are not there yet, so different companies do things differently. It's almost what we see also for the vaccine that we are living now for COVID. And quality standards, they have to be extremely rigorous, and they are. So quality of the autologous T cells. So I just explained to you that the one that we have are collected from the patients. So those patients, they have gone through a lot of chemotherapy. So we call them exhausted T cells. So sometimes, it is not the optimal setting. So we have to make sure that we have enough of them. And sometimes the patient is still myelosuppressed. So the quality of those cells also has not been optimal. That's why now people are collecting them in healthy donors. But with that, the allo-derived CAR Ts, we have other side effects that you have to watch for. So the good thing is that you have time to treatment get shorter. They become off-the-shelf product, and they can be manufactured in advance. So the patient comes to you, you can treat them in days. And the healthy individuals are the one giving those cells. However, as I was mentioning, you can have potentially severe and life-threatening toxicities. And in the case of allo-derived CARs, there's also some concern regarding the matching of those cells. So GVH is always a concern there, graft versus host disease. So the one that we already have and the one that we already have been learning quite effectively to mitigate and monitor is for cytokine release syndrome, CRS, neurotoxicity, also called ICANS, and B-cell aplasia. Because, you know, we eliminate with those technology B cells, and we have to be very mindful of that because this B-cell aplasia will give rise to opportunistic infections. So we have to monitor that and give them IVIG infusions. Very important, because sometimes a patient can walk into your office, post-CARs, doing great, no cancer is there, but the shingle that develop is many folds worse than in a patient that has an intact immune system. So that's also very important to keep in mind. And the pricing, obviously, which is another toxicity that is being also addressed by the new technologies, and also how we go around them. And with that, I want to introduce you to the three main ones, but we have another one also that just came to the market 2 months ago. And it's also for diffuse large B-cell lymphoma, but this is what we have here. So the price, as you can see, is between 370 and 475. So Kymriah is for ALL, but also diffuse large B. And the other that we have, so Yescarta and Tecartus are for non-Hodgkin lymphomas. Tecartus actually is against mantle cell lymphomas, and this is the first in that setting. They have different construct, and I put them here just to give you an idea. I don't want to, go too much into detail, but just to raise the fact that because they have different construct, Kymriah from the other two, they also carry different adverse effects. And most of the adverse effects that we see are related to the way that those molecules and those CARs are constructed. So this is the current scenario. Actually, no, this is 4 years ago in 2017. The amount of CARs that are being researched around the world. So at the end of 2017, we had 600 plus active CAR T cell therapy worldwide, 900 active INDs for cell and gene therapies product that were with the FDA. And the FDA is expecting to approve 10 to 20 gene therapy by the year of 2025. We are expecting in 2021, this year, to have the first CAR T for multiple myeloma approved. So here in the center, you have the ones that are approved. Thank you. And if you have any question, please.
I'm looking to see if you have questions while we do that, though. Can you elaborate a bit on the cytokine release syndrome? How often does that happen? How serious is it? And because if we start to do these at RGH, people will need to be aware.
Absolutely, absolutely. So thank you for this question. It's very important. So we have learned throughout the years that the cytokine release syndrome is highest, more lethal when the burden of the disease. That's why it's also important to make sure that the patient can be at the lowest level of disease activity, because that cytokine storm that we induce by infusing the CAR Ts is related by the amount of targets that it finds right out of the batch when we infuse them. So making sure that we take the patient that, when possible, right? Because sometimes you're going to tell me, But this patient already 4 lines of therapy later, and the patient is in relapse, and there is no way I can put this patient in complete response, right? And this happened. But those we will know that we have to expect more cytokine release syndrome. So the CARs are coming earlier and earlier in the treatment of those patients. And one of the reasons is also because they saw that because we have a lower level of disease activity, those CARs are able to deploy better and more efficiently and less toxicities, and they do a better job, so to speak. So it can be very severe. This is really, an MICU patient that you're gonna have sometimes. Most of the cases, I want to say, are what we call grade 1 and 2. They have fever. They might have some fluctuation in the blood pressure, but they are not hypotensive. They can tell you that, sometimes they're uncomfortable and coughing because there is some respiratory also discomfort. But most of the patient will develop fever. That's what we see. High ferritin, fever, and then we stop watching. We watch very carefully. When we reach the grade 3 to 4, then that's a patient that we call MICU. And as we had discussed, we have to work hand in hand with MICU because they can, develop hypotension, severe respiratory distress, and high fever. So we have very good drugs for that now. Tocilizumab and dexamethasone have been used very efficiently. And this has helped to bridge the patient from one point, which is the infusion of CAR T cells, and the other side, which is then free of adverse events. And this is also another very important notion. We know that CRS and ICANS are reversible. It's just a matter of bridging them from one side to the other. That's why that's the perfect patient for the MICU, because they just need support. We know that all of them recover if we give them the support on time. So that I think is very important. There is something, you're muted, Prad.
Yeah, there's a question about messenger RNA in cancer therapy. I assume they're talking about messenger RNA vaccines. I'm not sure. I have not heard anything about that.
Yeah.
There was a question about why the number of transplants in the 1990s dropped. And I think the answer is we were doing a lot of transplants for breast cancer.
Thank you, Prad.
90s, yes. And those, it turned out that was not useful. And when that indication went away, the number of transplants.
That's right.
And
That's exactly
Dr.
right.
Jackson asks, are bone marrow transplants being done or will be done at RGH? I'm going to let Anne answer.
Yes. So absolutely, yes. We are already working very intensively to make it happen. We believe that during this summer, at some time, we will have our first autologous transplant, meaning that for myeloma, either lymphoma. We are training right now nurses, nurse practitioners. We are reorganizing flows inside the hospital, making sure that everyone is aligned. There is a learning curve here. And I have to share that everyone has been tremendously, helpful. And I think everybody is extremely engaged also because there is a need in the community to have access to those therapies. So yes, we're gonna have it at RGH, and we are working currently to have them as soon as we can have all the stars aligned, because what we don't want is to have our first transplant without making sure that all the supportive care that is needed is in place. And this is exactly what we are working on. Nurses, they know, we have already very good nurses. We have a clinical manager, who is a BMT clinical manager. Her name is Morgan Fillet. She has extensive experience in transplant, and she came from Sloan Kettering, downstate in New York. And she was working with clinical trials, and she's also helping making sure that the training and all the pieces are in place, and to make sure that we can safely perform autologous, then CARs by the end of this year. And we are expecting by 2022 to have the first allogeneic stem cell transplant as well.
So Dr. Sabenghi asks, what is the expectation about long-term response? And will there be a need for repeating therapy to maintain response?
That's another excellent question. So when the first one, I'm going to talk about NHL, right? So non-Hodgkin lymphoma. I'm not going to talk about ALL because sadly, it's only for up to 24 years old. And I can tell you that for ALL, some of those patients are years and years and years out of the CAR therapies cured. And I just wanted to just quickly say that Dr. Carl June has several patients, including HIV patients from the very early phases, CARs, that are still out there 20 years later going to his office just for regular follow-up and cured. So this is for one setting. So now for non-Hodgkin lymphoma, and the data that we have most is about diffuse large B-cell lymphoma. We first thought it would be easy just to have a cure after that. So the fact is that the data is showing that the long-term response is seen in about half of the patients. So what this brought is that we first thought, okay, with the CARs, no more allogeneic stem cell transplant. We don't need them anymore, out. Well, not so fast. So now there is a new talk talking that maybe the CARs could be a breach, right? Because the depth of response is extremely good. So some of those patients relapse after that. So they could go for allogeneic stem cell transplant. If you ask me if we already have a firm and clear response to that, the answer is no. This is all in the works right now to see what is the right sequence, what is the right patient, and to make sure that we do not deploy a treatment that just the label to buy the box of the CAR-T is about $470,000. But if you connect with that, the hospital admission and everything else around, we are close to the $1 million. So this has to be taken into consideration. That's why to choose the right population and the right patient is extremely important. And I want to mention that this is several-fold more expensive than an allogeneic stem cell transplant that goes well. Okay.
I did want to mention, I don't know if everybody's aware, that our new floor in the building, the B6 floor, now has the ability to handle these patients, which we didn't have before. So at RGH, we've thought about doing autologous stem cell transplants in the past. One of the barriers has been that our cancer floor 5500 in the past did not have the airflow protection and so on that you need if you're going to do these treatments. So 18 of the 36 patients on 36 beds on the new B6 floor have the airflow requirements that you need for bone marrow transplant. So we now have the physical facilities to accommodate this. And as you can see, we also have the expertise. So between those two things, I think we're well positioned to get this going. Now, Dr. Lee asked, do the amazing costs of these amazing drugs mean there will be socioeconomic disparity in their use? Another good question.
Thank you for this question. So I have worked very closely, and my mentor is Dr. Nina Bickel at Mount Sinai, Disparities in Cancer. I personally think this is a very important topic because we want to make sure that all patients in need have access. I think this is also true for the vaccine, and we are seeing a lot of discussion around that as well. So what I can tell you is they're working on that as well. So historically, minorities do not have the same access to clinical trials. There are multiple reasons for that we can have dedicated talks around that. This is also true for allogeneic stem cell transplants, right? And obviously, it's also true for CARs. But there is already a huge amount of publication and studies going to how to best target those disparities and making sure that even if they exist currently, they do not stay in place that long. So we can make sure that our patients have access to all those cares. What I can tell you for sure that the first thing to happen in order to make sure that they have access is to set up a transplant center exactly like Rochester Regional Health, because this is a community-based practice. This is not an old, classic structure academic center. And with that, you ensure that your patients that are seeing in the community have direct access, to those treatment modalities, which is one of the things that actually attracted me to join RRH, because it is a community-based practice. So we are working on it, and as you can see, RRH is already working on it by bringing, this new modality of treatment in a community-based practice.
So we'll take one last question. One of the residents, Ekta Tirthani, asks, do we expect the side effects of CAR-T to be similar to immunotherapy, like the pneumonitis or the endocrinopathy?
That's an excellent question. So they are not the same. They're not the same because the immune pathways that are deployed by those different therapies are different. But as you know, in CRS, there is also respiratory distress. So there are some respiratory component in that, but not exactly the same. But what I can say is that the awareness is absolutely crucial, because there is, this idea that cancer is behind everything that happens to the patient. That's absolutely not true. So this is immune-mediated reaction. They are absolutely reversible if you start early and aggressively, and especially if you monitor your patient very aggressively. So they are not mediated by the cancer per se. So it's also, a new idea around cancer patients, because you're going to see this is, the way that we used to think about cancer. Once you have cancer, you will die of cancer. Not true anymore. That's over. You can die of the complication of the cancer therapies, which are immune-mediated and can be quite severe. If we go back to the first trials for melanoma, which is an immune-mediated by excellence, right, disease, you're going to see a lot of those therapies, including for renal cell cancer. We used to give them in MICU because of the whole immune, storm that we would create in those patients, and some of them would be cured after that. So the idea of a bridge is extremely important here. The immune reaction is transient. It needs significant support, yes, but it's transient and reversible.
Great. So we got a great participation for this. The number went up to 140 at one point. We're down to 123. Any closing comments, Ron, about Burnham and what Will would have thought about these kinds of treatments in the last few years?
Well, Will Burnham was an engineer from Kodak, and he was quite a smart guy, and he would have been quite intrigued by this. He wanted to know all the data as things were as he was undergoing treatment. And I know, thinking back, it's really 28 years this summer. So our group has expanded a lot since then. I think he came in the first week of July, and I think Peter had just started to join us then. So when you think back, the patient would have been amazed at the advances, and I think I'm kind of amazed at the changes our group has undergone over those years. We went from 3 hematologists, now I think there are 14 people in our group, and if you include all our affiliated hospitals, we probably have 20 hemonc doctors now that we all work together. And I also think that the audience should know that probably in the future, as this becomes more specialized, as you can see from those, from the talks, our group's probably going to have people that are really focused on just a few disease states. So 28 years ago, we all kind of did everything. But in the future, I think you're going to have people that are really going to focus on disease states just to keep track of all those multiple myeloma drugs, for example. We rely on Saad often because he has taken on expertise in that area. And I think that's really the future of hematology and oncology, is the rapid growth and great advances are going to require a higher degree of sort of differentiation of the physicians as well. But I think it's a very exciting time. I think that's one of the reasons that Hem/Onc has become a more sought after fellowship program, because it's such an amazing field. And part of it is, as I tried to point out in the beginning, the relationships with the patients, but part of it is all the advances. And when I was doing this, thinking back of the changes over time, the other thing that I thought of, which was kind of humorous, because Will Burnham worked at Kodak, he actually had his wife take a picture of me doing a bone marrow biopsy on him that he said was a Kodak moment. We don't really think about Kodak moments anymore. But last year, one of my patients asked if his wife could make a YouTube video of me doing his bone marrow, and that didn't exist in 1993. So another change over time. But I think the important thing is to see the advances in medicine. And again, I always like to make a point of trying to spend more time with the patients. And for the young doctors that might be watching this, it's more important to be at the bedside than at the EMR. So I think I'll end with that comment.
Sounds good. And speaking of YouTubes, this Grand Rounds is being taped, and the YouTube video will be out there by this afternoon, so you can pass that word on to your colleagues. And thank you all for attending. See you next week.
Thank you. Have a good day. Bye-bye.
Thanks.